Once again, colleagues, for joining our AMR CoP session for this month of September. We are delighted to come your way again. We hope our AMR CoP sessions have been of significant benefit to you and continues to be of benefit in our collective efforts towards improving AMR. Welcome once again. My name is Raymond Fachu, and I will be the moderator for today. Kindly note that there is interpretation service from English to French available in this session. To be able to access this service, find the globe icon at the bottom of your screen. Kindly click on that and select your language preference so you can better benefit from this activity. Today, our theme would be advancing AMR stewardship programs. In this session, we will discuss the successful strategies employed in different settings in expanding antimicrobial stewardship programs. You would agree that implementing AMR strategies would be influenced by the differences in people, beliefs, economies, etc. And hence, it will be relevant to learn as much as we can from those strategies that do work. As such, we will explore the global perspectives of antimicrobial resistance and antimicrobial stewardship, global and national action plans to combat AMR, implementation and impact of AMR surveillance and antimicrobial stewardship programs in Southeast Liberia. Within the 1 hour time duration, we will have Dr. Abraham Alabi, who is the technical advisor for health-focused diagnostics. He is a microbiologist who has worked in a widely multidisciplinary context in several low and middle income countries. His interests are in teaching and research in infectious diseases and mentoring junior colleagues to be successful scientists in their own rights. Today, Dr. Alabi will be sharing on establishing an antimicrobial stewardship program in 3 county hospitals in Southeast Liberia. Challenges, opportunities, and lessons learned. I now hand over to our esteemed presenter, Dr. Alabi, who will take it from here. Over to you, Dr. Alabi.
Okay. So once again, good morning. And thanks, Raymond, for the introduction. So I just quickly add that I'm a Nigerian. Like you said, I'm a microbiologist. And I currently work for a company called Health Focus GmbH. We're into health promotion and innovation, and particularly with health system strengthening, project implementation, and diagnostics, really. And I'm a technical advisor to the diagnostics section. And our focus on the diagnostics is actually to assist in establishing state-of-the-art medical diagnosis facility.
Dr. Alabi, your microphone is muted. If you could unmute, please.
Okay, you see. So have you heard what I've said before now? Or I should go over it quickly? So not to waste much time, I said I work for Health Focus GmbH. It's a health consultancy firm with headquarters in Potsdam, Germany. And we are into health system improvement and innovation, into project implementation and diagnostics. And I joined this company about 3 years ago. Before then, I was working in Gabon at the Medical Research Center. Before then, in Nigeria. Before then, in Cameroon, in Gambia, I mean. And then, so this is my background as a microbiologist. And today, I'll be talking to you about what we did in Liberia, which I was the project lead. So I'm actually speaking on behalf of a team of health-focused staff, Liberian staff, Ministry of Health, and GIZ that funded the project. So this is what we did, was to establish an antimicrobial stewardship program in 3 counties in the southeast of Liberia. So as a way of introduction, as people are coming in, and as a way of introduction, so I will be talking to us briefly about antimicrobial resistance, what do we mean, and also antimicrobial stewardship, or AMS. I will give some global perspectives. I will also talk on global and national action plans to convert this antimicrobial resistance. Then I will talk mainly on the project we implemented in Liberia. I will also highlight the impact of this project currently, some of the challenges we met, and then I will talk also about the opportunities both for the project and for all of us to contribute to preventing the spread of antimicrobial resistance. And then I'll conclude. So as a way of introduction, AMR or antimicrobial resistance could be described as when bacteria, viruses, fungi, and parasites, that is microorganisms, when they change over time and no longer respond to medicine, making infection harder to treat and increasing the risk of disease spread and also severe illness and death. So this is very simple, that this microorganism, since 1928, when antibiotic was first discovered by Alexander Fleming, it was like a magic wand. So you have an infectious disease and you apply the appropriate antibiotics and the infection is cured. But these days, many bacteria are becoming resistant due to many factors, some host factors and also some of our actions. So it's becoming increasingly difficult to treat, and it's a major problem globally. As you can see, if you look at the picture on the left, this is a teenager holding a sort of antibiotics packet, which is common. And also the other one is a hawker really selling antibiotics inside the bucket. This is practices still continue in many of our African countries, but we know this is not good. These are the factors that are actually driving resistance to some extent, indiscriminate use, and also improper storage, prescription, and the rest of them we'll hear about. On the other hand, antimicrobial stewardship are actually coordinated interventions designed to improve and measure the appropriate use of antimicrobials by promoting the selection of the selection of the appropriate optimal antimicrobial drug regimen, dose duration of therapy, and route of administration. So this is the goal of WHO, that antibiotics or antimicrobials should be used in the appropriate drug regimen, correct dose, duration of therapy, and then there must be correct route of administration. This is a map, a global map showing the result of a report which was commissioned by the British government, and this was published in 2014. And the lead author is Jim O'Neill. And this report actually highlights the problem of antimicrobial resistance and projects what could happen if action is not taken to prevent this problem. And the summary of this report is that by 2050, that the deaths that will be attributed to antimicrobial resistance globally will be about 10 million deaths per year. And most of this will occur in Africa. So from the map, if you can see, Africa is about 4.1 million, 4.2 million, and also Asia is the only part of the world that is higher than Africa, which is about 4.7 million. So if not more is done and the problem continues to increase, that by 2050, you'll be having 10 million deaths per year. And this is mostly in Africa. After that, 2014, there were 700 deaths per year. So this is the summary of this, and it's public, the reference is provided. Moving on from this, Why is not that? I don't know why my slide is not, okay. So in the next slide is a more recent report. So 2014 was 8 years ago, but this estimate was about 3 years ago, 2019. And this was published by the Global Burden of Disease Collaborative Network. And it shows that in 2019, 1.2 million deaths occurred due to antibiotic resistant bacterial infection. This is only about bacteria. And if you do the map, in terms of globally, that antimicrobial resistance accounts for more deaths than HIV, malaria, which we know and we know also cause a lot of death, but antimicrobial resistance is causing more than HIV or malaria. And in terms of rating, only 3 diseases, which are heart diseases, stroke, and dementias, that are actually above antimicrobial resistance. So direct attributable to antimicrobial resistance is higher, and also when you actually look at deaths that are associated, it's much higher. So this is saying actually there's a major problem. And of course, there's an economic burden to antimicrobial resistance. In Africa, for instance, you can see when people have resistant infections, they stay longer in the hospital, they spend so much money, they cannot work, so they lose economically. But this report was published last year, January, and it's from the US, United States of America, saying that this 6 group of resistant bacteria is costing in the US alone about $4.6 billion annually. This is more than the budget of several countries in Africa put together. So all these organisms are vancomycin-resistant Enterococcus, carbapenem resistant Acinetobacter, methicillin-resistant Staph aureus, MRSA, which we know of very commonly, carbapenem-resistant Enterobacteriales, extended beta-lactamase producing Enterobacteriales, and then multi-drug resistant Pseudomonas aeruginosa. This group of bacteria, resistant bacteria, they cost so much in the US. In Africa, we don't have this data, but definitely they're also costing a lot. Because of the situation, which is a very dire situation, there was need for global action on AMR. And then this global action was spearheaded by WHO. So the first is to make a declaration that as at now, antimicrobial resistance is one of the top 10 global public health threats facing humanity this century, threatening the effectiveness of the current panel of antibiotic drugs. What this means is that AMR is problematic and is increasing, and that drugs are no longer effective in many cases in treating infections. And number 2, that the overall goal of antimicrobial resistance surveillance and stewardship is to ensure, for as long as possible, continuity of successful treatment and prevention of infectious diseases with effective and safe medicine that are quality assured, used in a responsible way, and accessible to all who need them. So this is stewardship. This is the goal and this is the aim, but we know this is not happening in many of our settings and African countries. So as part of the global action in 2015, in 2015, the World Health Assembly approved a global plan for the whole world. And this was published in form of a booklet for everybody to use. And this has 5 strategic objectives. Number 1 is to improve awareness and understanding of AMR, like the World Antimicrobial Awareness Week. Number 2 is to strengthen knowledge through surveillance and research. For instance, submitting data to the Global Antimicrobial Resistance Surveillance System. And number 3 is to reduce infection through infection and prevention control, IPC. Then to optimize the use of antimicrobial medicine and to ensure sustainable investment. The World Health Assembly and WHO, they also encourage every country to also set up their own national action plan. And in Liberia, this was done very efficiently. So what you have, the picture on the right shows the National Action Plan on Prevention and Containment of Antimicrobial Resistance in Liberia, which was launched in 2018 and is to from 2018 to 2022. So actually, this is due for review this year. It's a well-described document that describes what Liberia wants to do in combating antimicrobial resistance. And it was also costed, which makes it slightly unique and different from many of other national plans. And following like in the global plan, the objective of this National Action Plan for Liberia is to improve awareness and education and training, to strengthen knowledge and evidence-based through surveillance, to reduce the rate of infection, and to optimize the use of antimicrobial medicine, and to ensure sustainable investment. So this was tailored along the Global Action Plan. As a result of this National Action Plan for Liberia, the government of Liberia, through the Ministry of Health and the German International Cooperation, GIZ, decided that they should set up a project to support this implementation of the National Action Plan. So this is the project I'm going to describe to you briefly. So the general objective of this project was to implement, to support the implementation of Liberia National AMR strategy as stated in the National Action Plan. Our specific objectives were twofold. Number one is to develop a pilot AMR surveillance system in the southeast of Liberia and to establish data that will inform and support guidelines development on AMR locally and nationally. And the second objective was to develop also a pilot antimicrobial stewardship program in 3 counties in southeast Liberia. The aim of this is to educate prescribers of antibiotics, antimicrobials, and to follow evidence-based prescribing in order to prevent antimicrobial resistance. You must have been hearing me using antimicrobial antibiotics. I need to make this clear. Antimicrobial refers to substances that will cure or kill microorganisms generally. So you are talking about viruses, bacteria, parasites, and fungi, whereas antibiotics specifically is for bacteria. And this project is based on bacteria, but the stewardship is cut across use of antimicrobial drugs. So the project size, like I've described, actually as in the southeast of Liberia. So the southeastern region of Liberia is made up of 5 counties. Liberia as a whole has 15 counties, which would be like administrative centers. This would be, in Nigeria, this would be like a state. So apart from the central government, we have the counties, the next level. And there are 15 of them in Liberia. And to the southeast, you have the 5 counties, Grand Gide, Sino, Rivergy, Grand Cru, and Maryland. But this project was actually based in the southeast, the 3 counties that are furthest from the center. So the capital is Monserrado County, which is Monrovia. So this project was carried out in Rivergy County, in Grand Cru County, in Maryland County. And I have to explain that each of these 3 counties have one major hospital. So, and the center county is Maryland, which is a bit more advanced. So what this project did was to develop a laboratory in this Maryland at the J.J. Dawson Hospital, and capacitated this laboratory to be able to do bacteriological analysis. So samples are collected from the other 2 periphery counties and sent to the Maryland county for analysis. Samples from the hospital in Maryland also is analyzed at that hospital, at that laboratory. So you have the Maryland hospital, J.J. Dawson Hospital in Maryland with a well-equipped laboratory, and then samples are sent from the 2 others to be analyzed at the center. So to start this project, we did what we call a SWOT analysis to look at the strengths, the weaknesses, the opportunities, and also the threats. So on site, as at May 2019, when the project was to start, we reviewed what was on ground. And in terms of strength, we found out that there were basic staff in each of these hospitals. We also have clear administrative structure, head of health in the county, medical directors, hospital, county diagnosis officer, and also technicians in the lab. There's also a lot of enthusiasm on the part of staff, and then we also have having patients load. In terms of weaknesses, staffing are really inadequate. For instance, at that time, there was only one regular doctor in 2 of the hospitals who also happened to be the medical director. Lack of stable electricity supply, internet connection problem, and then poor road network in the whole of the Southeast. Opportunities actually that was at that time, we were constructing a new lab, or a new microbiology lab, which would do laboratory and bacteriology analysis. Equipment were brought, and reagents also were brought. And then we also employed a full-time microbiologist, qualified microbiologist from Uganda, Mr. Ano, who is still there till now. And then in terms of threat, the weather is really a problem because accessibility is reduced during the rainy season. There is high staff rate and also attrition rate, and then there is effective implementation of that requires additional changes. What we mean here actually is that for stewardship, we are advising prescriber to change from prescribing empirically to doing it in a targeted form, waiting for lab results, and this requires attitudinal change. So to help us with this project, we set up both national steering committee at the Ministry of Health level, and also each hospital has steering committee members. And for the national, they meet once in a quarter, and then for the hospital, it's once a month that they meet to review the result. And there are clear chairperson and deputy to direct their affairs. And the role of these committees actually is to conduct AMS hospital ward round to review patients on admission who are being treated with antibiotics, to promote proactive and efficient stewardship strategies, and then to oversee the development and use and review of local antimicrobial guidelines. So, this committee, we developed what we call the AMR Steering Committee Program Antibiotic Prescribing Guidelines for Common Infectious Diseases. This was developed by the committee, and what you have there is the second edition. This is reviewed every year. So the last revision was done last year, December, and we based the revision on following the Liberian National Therapeutic Guidelines, and also the local antibiotics susceptibility result, and then WHO treatment guidelines. Secondly, also in this guideline, we also describe the infections that we are interested. For the stewardship program, we focus on 6 diseases or 6 infections: meningitis, gastroenteritis, pneumonia, wound infections, skin and soft tissue infection, and then urinary tract infections. And this on the right column are the type of specimens that you collect for each of the different kinds of infections. So for instance, for meningitis, we collect CSF, cerebrospinal fluid, and blood. For gastro is stool. For pneumonias, respiratory tract infection, and others for wound swab. And then for urinary tract infection, we collect urine. And this is the protocol for the stewardship program. And what it means that there are two meeting points of the committee with the patients on admission. So on day 1, the steering committee members, which are made up of doctors, nurses, physician assistants, pharmacists, lab scientists, they conduct AMS ward round, and they identify patients on admission that has any of the 6 targeted diseases. And then the physician managing each of these patients will describe the case to the committee, and the committee will observe the patients and also look at the case note. And then this committee will review each patient's case and make appropriate recommendations based on standard guidelines. For instance, if somebody has a case of wound infection, normally clinical samples like a wound swab needs to be sent to the lab for analysis. If the wound swab has not been sent at that time, they will recommend that it should be sent. We also look at the drugs that are being used and advised. And then the patient's information are documented in a confidential case report form. And there's a follow-up visit on day 3 by this same group to see the same set of patients. And on this follow-up visit is to see how things have changed in terms of the patients, in terms of improvement, or has it deteriorated, has the patient been discharged, or unfortunately some cases as the patient died. And more important also, importantly, is that they also make sure that the recommendation they gave on the first day of visit, whether this has been followed up or not. For instance, if they say sample should be sent to the lab for analysis, has this sample been sent? If it has been sent, has the result come back or not, and the follow-up, just to have optimal patient care and best practices. So this is the overall goal of the steering stewardship committee. And then follow-up actions actually is that after gathering this data, the data are entered into a dedicated database. These are analyzed and used appropriately to improve patients' care and management. So there's also, today we are talking about the stewardship, but we also have a surveillance aspect. in which case that we collect clinical specimens from each patient from each of the 3 hospitals. And these specimens are transported to central lab for analysis in Harper. And then the specimens are analyzed by standard and quality assured methods. And then bacteriology research, which is identification as antibiotic sensitivity research, are transmitted first by electronically, and also hard copies are sent to our 2 dedicated trained drivers. And then these results are received by clinicians at the requesting hospitals, and these are incorporated into patients' treatment. The AMR results are also reviewed and resistance patterns discussed at monthly meetings of the steering committee of each hospital. At the national level, the AMR surveillance data of the result are also fed into national AMR data through the AMR technical working group, which is the Ministry of Health. And then these are used for appropriate purposes, like, for instance, submission of data to the global surveillance system. I don't know why. Okay, so I just want to quickly show some of the results that we have, preliminary results. This covers the data that we collected from October 2019 to October 2021, last year. And so this is about the surveillance result. On the left, we have the total number of specimens collected, which was 860. And for the 3 hospitals, J.J. Dawson Hospital, the Raleigh-Time Hospital, and the Fishtown Hospital, these are the county hospitals. The highest came from J.J. Dawson Hospital, which is about 45%. And talking about the type of specimens analyzed, urinary tract infection, skin and soft tissue infections, blood infections. These are the main 3 types of specimens that were collected over this period. The small, this is Southtown Health Center, which was attached to the Raleigh-Time Hospital, really. So then in terms of the isolates, gram-negative bacteria you see on the left, we had a total of 245, and the main isolates, gram-negative bacteria, are Escherichia coli, Klebsiella pneumoniae, and Pseudomonas aeruginosa. For the gram-positives, we have majority was Staph aureus, and probably because we have soft and skin tissue infection, wound infection, blood infection, so the majority was Staph aureus. But we also have other bacteria like strep group B, which are also present. This gives a global resistant pattern of associated bacteria to commonly prescribed drugs at the 3 hospitals. So in terms of resistance, ampicillin, penicillin, the Septrin, they are more than 70% in terms of resistance. So which means these drugs currently are becoming less effective. So they normally will not recommend this in treatment. So this is the pattern that we have. The others are still effective. Clindamycin, Cipro, gentamicin, these are still very effective, very low resistance. But for the first 3, including tetracycline, they are over 50% resistance rate. And then for the common, these are the overview of commonly prescribed drugs at the hospitals. So this is like a point prevalence survey of the antibiotics that are prescribed within the 3 hospitals. And ceftriaxone happens to be the highest, followed by metronidazole. And then this gives a brief overview of the effectiveness of the stewardship program. So what you have here is uptake by clinicians of the recommendations of the AMR steering committee for patients' admission. And as you can see, in 85% of the cases that were admitted, the clinicians and the staff managing the patients, they follow the recommendation of the steering committee members. So this is working effectively. These recommendations were not followed in 12%, which is we are still working on to what we expect, or is 100% followership of this recommendation, because these recommendations are based on many factors and by experts in the field, including clinicians. So, and in 30%, the recommendation was not were not available. So this, excuse me. So this talks about the overview of commonly no, I think we have done this. Ceftriaxone as the highest, okay? No, something. So this talks about the impact of this AMS program in the 3 hospitals. Over time, we have seen that the period of review, that there was improved clinical practice and patient care at the 3 hospitals. So in terms of increased targeted antibiotic treatment, instead of using empiric treatment, there were short hospital stays for most patients, reduction in medication side effects, and reduction in antibiotics misuse. And on the positive side also, that we have well-trained staff on both surveillance and also stewardship at the 3 hospitals. And as a matter of fact, we have many training workshops where we brought experts and also national staff to support. Another impact is that there also, for now, there is a quality bacteriology analysis at the GmbH Microbiology Lab. We're also keeping the Liberian on the global, we're helping to keep Liberia on the global map through the annual AMR data submission to GLAS. So data from this project and from 2 other labs were submitted last year for the first time. For the first time to GLAS, the Global Surveillance System. Also, some of our staff presented many abstracts in many conferences, both locally and internationally. And I want to say here also that just last month, the county pharmacists for Maryland County was able to present our data at the National Science Conference, and actually was adjudged the 2nd best presenter. So this is actually working. And of course, we also have a publication already from the work, which was published in June this year. And you can see the reference there. And we recorded a number of success stories. Success stories are stories that we document that due to the intervention of antibiotics of the stewardship committee, patients that are difficult to treat were effectively treated. The first case recorded was a pregnant woman that came for delivery at the GmbH Hospital in October of 2019, and a cesarean surgery was carried out on her, and the baby and herself were okay. So after observation for 4 days, she was discharged to go home and continue the treatment. But about 2 weeks after, she came back to the hospital with a wound breakdown, and she was admitted and being treated for about a week, and there was no improvement. But fortunately, this lab was established and starting at that time, so sample was sent to the lab, and a highly resistant rheumatoid isolate was found that were resistant to all the drugs except imipenem. And imipenem was not even in the hospital, but this was ordered, and when it was used for this patient, after another 4 days, he was well enough to go home happily with the baby. This was really a big impact. And we also have several of such documented. This is a more recent result from August last year, on the 14th of August. There was a case of very chronic UTI, urinary tract infection at the Raleigh Time Hospital. And you can see the isolate was resistant to all the drugs tested again, except imipenem. So if the lab is not there, or if progress is not there, then this will be treated blindly using all types of antibiotics. But with this kind of result, intervention is targeted, and then the patient recovers quickly. This just to show that this program is making a lot of impact. Just to show you some of the activities that took place in the implementation of this project. The first was the first national stakeholders meeting on the right top left, which was in June 2019 in Monrovia. This comprises of all stakeholders led by the Deputy Minister of Health, Dr. Francis Kate in Liberia, and then officials from the ministry, officials from the county, officials from the hospitals, and also from GIZ and all the interested partners and ourselves, focus staff. On the right top, you see the ambassador of Germany at that time to Liberia declaring open the newly refurbished hospital lab, microbiology lab. And down on the left is the steering committee of GmbH Hospital meeting. This they do once a month to review all the data for resistance and also for stewardship. And on the bottom right is a lab workshop which was held in March 2021 in Harper, Maryland. So a lot of training and workshop activities. On the left, in this picture, we also saw participants are facilitated at an antimicrobial stewardship training workshop in 2021 May, and on awareness campaign in the city of Kappa. So we go out once a year to do awareness. So we have a march, and then we gather in the center of the town. This is done in each of the counties. People ask questions so that to educate them more, the community, about AMR. And from time to time, we also feature on radio programs for people to know about the project. So in terms of challenges, a lot of challenges, but these are the major ones, that deplorable road conditions in the southeast, especially during the rainy season. On the picture on the right, you can see our driver really bringing samples from Valentine Hospital to GmbH and struggling through very difficult terrain. Limited number of qualified and trained staff. There's also some ignorance and traditional beliefs that are fueling antibiotic misuse and abuse in the community. Occasionally, also there are stockouts of some antibiotics. This happens, I think, mainly in many of developing countries, not only in Liberia. And in Liberia, also, Liberia provides free health services. So patients don't pay for lab examination, they don't pay for consultation, they don't pay for drugs. This is funded by the government. And it's a lot of a burden because resources are competing with other sectors of the economy. So this is it's affecting in a way. And of course, there was COVID pandemic, which everybody knows of. This project was from 2019, October to January this year, to be handy. And you can see this was the major period of pandemic, COVID-19. But because the project was hospital-based, we were still able to operate. So in terms of opportunities, this is a very good paper published early this year in March by a group of authors led by Mr. Mifin Mkundu, who is the head of REACT Africa. And it's actually calling everybody to action that antibiotic resistance, calling time on the silent pandemic, that this is a pandemic going on silently, and then we need to do something about it. So, and there are opportunities that we can really utilize in that there are a lot of guidelines already available by WHO, by CDC, on how you can carry out stewardship. So you need leadership, you need human resources, education and training, treatment guidelines, interventions, monitoring system, reporting and feedback, links to IPC, and to show that every sector of the hospital setup or management should be involved in stewardship. So there are already documents that we can rely on to set up programs. WHO also went further to classify antibiotics into 3 groups. There are about close to 300 antibiotics that have been properly classified into access group, wash group, and reserve group. And the recommendation is that you start with the access group, which are not easy to become resistant, and then you follow with the wash group, and the reserve group are antibiotics that you rarely use, only in most difficult situations and instances. So these are guidelines already available internationally, and that people have access to for us to do stewardship within the hospital and our setup, really. So also there is the World Antibiotic Awareness Week, which really is between November 18 to 24 every week. This is celebrated globally, and this was the 2019 edition in Monrovia, Liberia. I will tell you that the Minister of Health was part of this parade on this particular day, and then there was an indoor program after. So this is something all of us can participate to let people know that we need to handle antibiotics with care, and that antibiotics are not food that we should be eating at any time. Also, there is so much of emphasis now on World Health. The picture you see here actually is from Uganda, and this is a pond of river where you have animals drinking from there, children also playing and drinking, probably adults also fishing. So, which means really there's interaction between the environment, the human, and the animal sector. So we can contribute to how to stem the spread of infection, cross-infection among this group. And this is also a published work in Nature, so you can, the reference is there. There are opportunities for training and education. A lot of free online courses, which are listed here by WHO, by the CDC, America, by European Center for Disease Prevention Control, and international master class, which is held once a year. This year's edition was yesterday, and I was part of it. So it's a whole day meeting where people speak on antimicrobial resistance and stewardship. And it was really very useful. And it's open to participants from the local country free of charge. And there's REACT, which is a very useful group internationally and also in Africa. Their headquarters is in Nairobi, and they are doing a lot in terms of training and promoting stewardship activities. Also, there are a lot of funding available that we could compete for. The Fleming Fund, which is part of why this program is happening, what we are presenting now. There's also a joint program initiative on antimicrobial resistance, which is Europe-based. There's Pfizer. Actually, there's a current call by Pfizer now for stewardship. The closing date is next month, the 13th of next month. And you can request for up to $100,000 to improve stewardship in your setup. And there's also international development partners like GIZ, USAID, MSF, and many of them. And of course, there are African initiatives like ASLM. They have a training academy, and there's qualifying the workforce for AMR surveillance, which is the QAS program. Also, in combination with CDC, Africa CDC, they also have the mapping, AMR and AMU partnership. And the result was presented last week, which they conducted the antimicrobial surveillance data from 14 countries in Africa. And truly, these are very useful information that were not there before, and now they are available. There is the African Research ASLM Fund, the RF, based actually inside in MRC, the Gambia. And there's also the African Research Network on Neglected Tropical Diseases. I brought these two organizations there because they also give small grants to support young academicians and researchers to work on this. And I think this is something also that CDC and ASLM can consider. What are the recommendations? First, we want to recommend that national governments need to prioritize AMR surveillance and stewardship because this saves lives and reduces costs, including Liberia and other countries in Africa and globally. Also, there is need to institutionalize AMR and AMS program to ensure sustainability. This is very important. Need for increased awareness through education and training, need for effective sanitation, hygiene, IPC measures in homes, communities, hospital offices to reduce the incidence of infection and the spread of antimicrobial resistance. And that we all need to be vanguards and champions of AMR and stewardship. So I'm actually calling on all of us that we have a role to play. And to conclude, I want to highlight on these three statements that the first one is that AMR and AMS program, we have successfully established this in rural, difficult to reach Southeast Liberia. And this is positively impacting patients' care and treatment. And if it can be done in Liberia, definitely it can be done in other African countries and globally. That you and I we can set up or be part of AMR, AMS activities in our healthcare settings, in our hospitals, in our research centers, we can be part of this. And then this statement is from the WHO Deputy Director General, Dr. Susanna Jacob, on the World Patients Day this year, 17 September. This was last week, I think, or last 2 weeks, that we know medicine saves lives, but they can also harm in cases where they are inappropriately prescribed, taken the wrong way without proper monitoring, or are not an adequate quality. So we all need to ensure that antibiotics remain useful. And there's this African saying, proverb also, that if you want to go fast, you go alone. But if you want to go far, you have to go together. So for us to go far and be able to combat antimicrobial resistance, we have to go together. And finally, I want to acknowledge a lot of people that have contributed to the success of this. First, to acknowledge the ASLM and the AMR community of practice that they may be supporting to present. I'm a member of ASLM and I'm happy to do this. I think it's very useful and want to encourage that this should be maintained. And on the part of the funders, the German government through the GIZ and the International Development Corporation, they funded this project. The Ministry of Health and the people of Liberia, Ministry of Health really cooperated with us. We have cooperation to the highest level, up to the deputy minister level, who was very much actively involved, coming to our workshops to encourage participants from time to time. The National Institute of Public Health in Liberia, they also supported very well. Of course, there's partners in health, which are actually partners in progress, This is an American agency working majorly in the southeast of Liberia, and they participated very well, and they are part of this project. Of course, my organization, Health Focus, we're based in Germany. We are the implementers of this project, so they actually did very well. And I was having a team of 5, including myself. So that we have 2 drivers, we have a national coordinator, they also have an administrative assistant, and then myself. We actually carried this project completely from the beginning to the end. The participating hospitals, the 3 hospitals that I've mentioned, and the communities around these hospitals that they are serving, the steering committees, both at the national level and the hospital level. And of course, the Liberian community and the people that we work with. And of course, we also invited some short-term international experts to assist us from Germany, from Gabon, from Nigeria, from Tanzania, to help with either stewardship aspect or antimicrobial resistance surveillance aspect in terms of training. And of course, my very lovely wife, who was with me throughout this and really supported, you could actually imagine what would happen if we have fought this morning. It would not be easy for me to present. So she's been giving me peace and also supporting all we are doing. So we're in Liberia for this period, and everywhere we have been, we've been together. So I really want to appreciate her. And I want to thank you all, from everyone, from wherever you are listening, and please see how you can contribute to reduce the impact of antimicrobial resistance in your locality, in Africa, and globally. Thank you very much.
Thank you very much, Dr. Alabi, for that insightful and deep presentation. The chat box is buzzing with questions, and I would want to take the opportunity to dive straight into it so that we can have some responses to these very interesting questions. I'll take the first one from Dr. Suleiman, who says, what is the most prevalent factor for antimicrobial resistance observed in Liberia? Dr. Alabi.
Thank you very much for that wonderful question. We didn't do a survey, but what we can say, there's a lot of factors contributing to resistant development. And the first actually is that self-prescription is very rampant. And I think this happens also in many developing countries, in many of our countries in Africa, really, that first people go to before going to the hospital, they go to the pharmacy and they just request, I want tetracycline, I want ampicillin, and the pharmacist gives to them. So, so I would say in terms of what is driving, a major factor is that people have access, uncontrolled access to antibiotics. So, and when you continue to use indiscriminately, resistance will develop. So I would say this is the major factor, really, that control of access to antibiotics is very weak.
Thank you very much, Dr. Alabi. And I believe that is one of the key reasons why the antimicrobial stewardship program becomes even more important in Liberia. We take another question from Mariatu, who says, how can the AMS practice, which is mostly championed by nurses or dispensers, not always doctors, in health facilities in low and middle income countries, be positively influenced to reduce AMR?
Thank you also for a very wonderful question. So from our own experience, what you need to do is to build confidence. I would be surprised if you say only nurses and prescribers are into stewardship. So in Liberia, what we have is that you have the medical doctor is the head of the program. And then we have pharmacists, we have nurses, we have physician assistants who are nurses that are trained to also prescribe and examine patients. And what helps us is that we have a committee, this is what we call steering committee, AMS steering committee. So what I would recommend is that for your stewardship to be effective in any hospital, you need to have a committee of a few people, champions. For us, we have like 11 members, usually odd numbers, so that if you have to have a vote. And they go on the ward rounds together, and then they also analyze the results once a month and advise. And some of the results are presented at doctors' meeting, like the best practices meeting, at every opportunity. So you need first trust, and you need a few people that are committed to really champion this. And you need to involve the doctors because you are working on attitudinal change. One thing I need to mention about also Liberia is that before this project, there was no bacteriological analysis in any of these 3 counties. And I think this is a situation in many of us places also. So, which means people were prescribing before without doing laboratory tests. Now you brought in laboratory tests. You need to talk to people to let them know and for them to change, because they are used to prescribing without going to the lab or looking for lab results. Now that the lab is available, you need to talk to them to always request and to monitor. So this is the only way you can make it effective. But everybody needs to be involved, including the doctors. And you make them realize it's not that you are monitoring the activities, but just ensuring that patients are treated with optimal care and procedures. Thank you.
Thank you very much, Dr. Alabi. Another question for me is, you had indicated that there were some beliefs that was contributing to AMR in terms of the attitudes of the people. It will be interesting to know what some of these beliefs are as this project was being implemented.
Okay, through our awareness campaigns, we find out many of these beliefs. The first one actually is that first, there are people who believe that they must use antibiotics. For instance, we found out that some young ladies, so after their menstruation, they really believe that they must take antibiotics to like cleanse themselves. So there are no infection, but they just take it. Another belief also is that if you go to the hospital for consultation, you must also have you must come back with antibiotics. And I witnessed a particular case when I first got to Liberia, the Prevalent Hospital in May 2019, that a lady came for consultation and the doctor was telling her that you don't need antibiotics, you just have common cold, I will give you paracetamol, you go and rest. And so. But this lady insisted that, no, I've left my home for the whole day, I need antibiotics. Even if I don't finish it, I can use it another time when I'm sick or give to my neighbor. All these are beliefs really that driving this really. And so people believe the drug needs to take it, and resistance develops the more you are exposed to these antibiotics. And some people also believe that it's actually their body that becomes resistant to antibiotics and not bacteria becoming resistant to antibiotics. So these are things you need to work on really. So in the community, there are a lot of beliefs really. And this is why I'm also happy to say that the AMR Technical Working Group in the Ministry of Health in Liberia, they are planning to conduct a nationwide knowledge, attitude, and practice survey to really document all these factors that we found, and maybe many more that are hidden. Thank you.
Thank you very much, Dr. Alabi. And I think we can have time for one last question, and then we'll move on to end today's session. I'll take this from Mwanda Mba, who says that this project was carried out with support from GIZ. What are the measures that the Ministry of Health is taking to ensure that this laudable initiative continues? Would you be able to respond to that, please?
Yeah, thank you very much for that wonderful question. And really, I would say this is, we talk about sustainability. And I can tell you that this is continuing in Liberia. The project officially ended in January this year, January 31st. But you can see that I presented results as early as last month, August, and they still continue. So what I would say in practical terms, in 2 of the hospitals, J.J. Dawson Hospital and Rally Time Hospital, they have continued this project and running it despite the fact that the funding from GIZ has stopped. In Fishtown Hospital, they are struggling to do this also. But also on the good news actually is that the GIZ is thinking again to really reinforce, to support for maybe like 2 or 3 months to really strengthen this. But In terms of sustainability, the project stopped, funding stopped January this year, and up till now, they are sustaining, and I believe it's going to be sustained. And from this project also, there's actually another project that is in the central part of the country, being funded by USAID. So you are right, sustainability is very important. And we discussed that right from the beginning of the project, how to sustain it. So it's working and it's running, and I believe it continue to run, even when funding from external funders stop. Thank you.
Thank you very much, Dr. Alabi, and the responses are really on point and most appreciated. Could you kindly stop sharing your screen? Thank you.
Okay. Okay.
And so, colleagues, we want to thank you very, very much for your time and for making it to today's session. We'd like to inform you that there would be certificates of participation on this session. And so please feel free to log on to the ASLM Academy, and then you would be able to access your certificates using the code that will be displayed on the screen. We are happy to come your way again with the next AMR CoP session, and we hope you would be able to join us as we continue to share expertise and share experiences insofar as AMR is concerned. On the screen, you have the code. Please feel free to write it and use that to be able to access your certificate of participation. Thank you very much, Dr. Alabi, for making time for this. Thank you very much, colleagues, for making time to also learn in. We will come again your way in the next month of October with yet another exciting session, and we hope that you will all make time to join. Thank you very much, and happy weekend and a happy new month to all of us. Bye for now.